We're going to wait a few moments till we get some more members. Let me say this to those members, we're doing hearing only today. That does not mean that your bill does not have a chance to get through this year. We do not. I'm not using subcommittees presently for this committee, which is something we may look to at the future. So when we're doing hearings, that's sort of like a subcommittee. I want the committee to hear the information. Doesn't mean that you won't be circling back in time to get your bill through. Okay. Okay. I think we're close enough. Senator Estevez, would you like to go ahead and present Senate Bill 199? You can do it from that mic right there.
Thank you, Mr. Chairman.
Go ahead.
All right. No, thank you so much. Colleagues, I would like to present all of you with an opportunity to set up our state employees, including our teachers, on a stronger path for financial retirement, and allow those employees and teachers to save for their health care. The purpose of SB 199 is to give authority to the Department of Administrative Services to expand their flexible benefit offerings to include health savings accounts to all employees. Currently, Georgia law does not confer a broad mandate upon the department to add benefits as needed. Instead, it specifically enumerates the flexible benefits that the department is authorized to offer. And unfortunately, health savings accounts are not included in that, which makes sense because the statute was passed in 1991 and Congress created the health savings accounts in 2003. Health savings accounts should not be confused with health spending accounts, which the state currently offers all of us. Those health spending accounts have to be spent down at the end of the year, and the tax benefits are very limited. Whereas with health savings accounts, employees in high deductible healthcare plans can roll that money over year after year, tax-free, and if the employee saves it through retirement through the age of 65, you can go from having to spend that money on health expenses to spending it on anything. It's a wealth building vehicle for those employees as well. And on top of saving those state employees tax money, it also saves the state money because we would save on FICA taxes. So for example, if you have 100 employees, each contribute $2,000 through HSAs through the pre-tax payroll deductions, our state would save about $15,000 in FICA taxes, and those employees would save about $50,000. You multiply that out to the roughly 11,000 employees and teachers who are in high deductible plans across the state. Those savings would be significant not only for those employees but also for the state. So I ask for your favorable consideration to add this great benefit to our state employee plan, and I'm happy to entertain any questions y'all may have.
Maybe any questions from the committee? Representative Cannon.
Thank you, Mr. Chairman. Is there a limit to how much an employee could put in this account?
Yes, so annually there is a limit. I believe this year it is a $3,500 limit. I can confirm that for you, but there is a limit that you can contribute annually, and that grows as long, and you can contribute, take it with you as long as you are in a high deductible plan wherever you go.
Gotcha. Thank you. Thank you, Mr. Chairman.
I see no further questions. Thank you very much.
Thank you, Mr. Chairman.
All right. This thing's just not reacting with the two. Yeah, I've been hitting it. Okay. All right. Let's hear Senate Bill 76 by Senator Merritt.
Thank you, Mr. Chairman, members. Good afternoon. So I bring to you today SB 76, and it is simply to cap insulin costs at $35 for state health benefit plans. Right now, there are over 1 million Georgians that are diagnosed with diabetes. My purpose here is just, and I would love to extend it to all of Georgia, but my purpose is just to allow for more options for low-cost insulin. So why not start with our employees, our state employees, and set the standards? So it would benefit all of our state employees. So think about our teachers. Right now, we are trying to retain and attract more state workers. I think this would greatly help those that are insulin dependent. Hope I have.
Let
the
me
right-
tell the committee that the bill you have is the wrong bill. That's an HB. They're on the way to get the SB right now, and I apologize. She's got it right
Okay.
here.
Are we good? Almost
Yeah,
good.
she's gonna hand it, pass it out now.
I
Give
just
them
wait
just
for
a
everybody to
second.
get a
You can-
copy.
I'm gonna let you start from the top.
Why not?
Why not? All right, go ahead.
When
Thank
we're
you.
ready. Okay, so this is just capping insulin costs for state health benefit plans at $35. As I was saying before, 1 million Georgians are diagnosed with diabetes. I would love to be able to extend this option to 1 million Georgians, but it's a little easier to work with our own state health benefit plans as we can set the standard. So this will, again, benefit our employees. Think about our teachers. At a time where we're trying to attract and keep workers, this will help us help and retain those state workers. We have many members that are insulin dependent. I grew up in a family that insulin dependent family, diabetes. I'm already predisposed for it myself. I don't have it right now. You know, I'm not a medical doctor by any means, but this is an opportunity for us to lower the cost of insulin for our state employees. The cost of the program is very low. For 1 year, we're looking at $306 to cover approximately 2,400 members. You can double that because we do have an option there for a 30-day supply at $35 and a 90-day supply at $105, which is more savings. So yeah, that's pretty much the bill. Is simple, and I ask for your favorable consideration and open questions.
You do have a question, Representative Newton.
Thank you, Mr. Chairman. Thank you for the bill. Right here.
Oh,
Sorry.
yes, sorry.
Um,
Sorry,
I
don't
did
know.
see on line 38, you're talking about 35% of the negotiated price,
Y'all probably
net of
could.
all price concessions. Is that, what's included in price concessions?
I
far as
don't
you know, is that-
have your. I need to.
Am I on the right, can you read your LC
I don't have
number?
your. I have the green version, not the blue version. You gotta see it.
Do we have an extra copy? Could you read your LC number that you're
Net
reading?
of all
off of?
price concessions received on behalf of such plan. Price of cover.
You're reading from LC 52028-3S. Is that the LC?
Yeah. The definition of concessions, I would have to look honestly to see what we mean by what that is meant by using that term.
But I do appreciate that you have the lesser of all of these, and so I appreciate that. I think that does, it could be less than the $35 if after price concessions, rebates, whatever, the
It could.
price was less than that, then 35% might be 35% of $40 or something.
That's
So
correct.
it could be significantly less expensive. Thank you for that.
Thank you.
Representative Mitchell.
Yeah.
Representative Mitchell.
Mr. Chair, thank you so very much. I happen to know how hard the author of this legislation has worked on this issue, and consistent with a number of companies, Eli Lilly, to name one, has already made this kind of reduction possible nationwide. I see the bill as hearing only, but I happen to know that the chair has a discretion to entertain my do pass motion.
And I just want to make a comment about the Eli Lilly. Just keep in mind, Eli Lilly is a company. They're a corporation. They are for profit. At any time, they can raise that cost. If it's not profitable, they could say, "Hey, we don't. We want to raise the price." We are setting a standard here about insulin costs. So, thank you.
Good try, though.
Good try.
Who do we have next? Knight. Let's see, 5. Representative Knight.
Thank you for your effort here. I agree. We've been fighting here for a number of years with the high cost of prescription drugs, and quite frankly, the system that is out there in the United States today that lacks any kind of transparency as to the real cost of prescription drugs. But with that, that's where I want to go back to is cost. And you said that Eli, I read or were familiar with the news release that they had done this. But that demonstrates that the actual cost is actually, more closer to probably what you're seeing here or what you're proposing. But the problem is in these negotiations and the contracts, we're getting charged a higher cost. And then again, I think to Chairman's earlier question about what these concessions are in regards to rebates, how much is actually being made by these companies. And I agree with your sentiment here, but what we've also tried to do for a long time is get to the actual cost of not only this particular drug, insulin, but all drugs that are being, basically marked up to unbelievable levels. It's costing not only us as citizens, the insured, but the state a lot of money. But I applaud you, but if we do it for one, are we pushing things cost on to others? I mean, how are we going to get to this across the board?
Now, when you say to others,
Other drugs and to other prescriptions are out there that maybe your neighbor is taking. Are they just going to mark those up? And that's the problem. It's whack-a-mole within this industry. You may get a concession here, but on the other hand, they raise the cost or the price,
some
should I
other
say,
drugs.
with your neighbor.
Yep.
And that's the problem. I think
Right.
we've talked about this many times, haven't we, Representative?
and that could very well happen with other drugs. I mean, I'm just dealing with insulin right now. We have like older folks and people who are rationing insulin right now. So I know
I
insulin
agree
cost
with
is
you. It
very
is a-
high, and
it
there's
is a
only
big thing.
3 major manufacturers right now.
And there's a study, there was a federal study on this, and it was very interesting. If you don't mind, I would, if we get a chance, maybe drop with the committee or the chairman, you had an estimate of what this would cost.
Mm-hmm.
If you have that documentation, could you leave it with us?
Yes, y'all should have got the fiscal note. If you didn't, I will get that to the chairman. But that
Okay,
should have been
okay.
dropped in your packets. But I do have the fiscal note on that.
Thank you.
I don't remember seeing it, but that
Okay.
doesn't mean it's not here.
We can get it to
Do we
you.
have a fiscal note? We don't have it.
We can get it to you.
Okay,
I was trying to see was my assistant here, but I can get it to you.
okay, we got time. Representative Schofield.
Thank you, Mr. Chair, and thank you so much for doing this. We've had a lot of conversations about the cost and cost savings, and while we can't fix everybody's problem right now, I think it's a good gesture that we look at those that are insulin dependent and start somewhere. So I just wanted to thank you. I tried to put this up about less, but I'm glad we're getting it through. I wish this wasn't a hearing only because this is needed.
Yes.
But we can't solve everything, but we can do a good gesture and start somewhere. So thank you.
A little bit at a time.
Representative Petrie.
Thank you, Chairman. And my question was, I was going to ask the same thing about a fiscal note. So can you help me? So first of all, we're doing everything we can to hire and retain state employees and teachers. That's a good thing. Anything we can do to that end, I think, is helpful. But I did want to ask you about, you mentioned 2,400 members. So can you tell us, even though, we don't have the fiscal note, that was going to be my question. I think you've already answered that. What was the, do you recall, can you tell us what that is?
It was $306,000.
$306,000
right.
would be the cost.
Yep.
And you mentioned 2,400 members. So we've got how many state employees? I mean,
Oh, we have a lot. This
well
is,
over
I don't even think this is
500,000.
inclusive of all of them.
Yeah, I understand, but that's actually a smaller number than I thought, considering we've had a lot of conversations about the health of our state workforce in the past, and so about 2,400 members, about $306,000 cost to implement this. Thank you, and we'll see the report soon, I guess, Mr. Chairman. Thank you.
Guys. I mean,
Representative Hatchett.
Thank you, Mr. Chairman.
$150 a month.
Senator Mayor, I was just curious, what's the cost of insulin, like the range, like what do the different insulins cost if you're buying them? I don't have any idea. Just curious.
Offhand, I don't know, honestly. You know, I can get those numbers too, but I know it's well over 170.
I don't know either. That's why I
Yeah,
was just-
no, that's a good question, but it is high. Let me see if I can get that for you. And I think I might have that somewhere. We can probably Google the average cost. What is it?
Yours, if that's mine.
That's what I was in. That sounds about right. I said 175, so I was close. Close. Sounds about right. Do we get it? 176, I think. 125 to 176.
Yeah.
Current cost.
Is she still looking? Oh, okay. Representative Newton.
Thank you. Just one quick, this is for all insulin-dependent diabetics on state health benefits. Is that the correct group
That is
we're
correct.
talking about? My understanding, and if there's somebody here from SHBP, they can correct me, that we had about 620,000 covered lives. So we were just Googling that about 6% or a little under 6% of Americans have diabetes. I don't know that Georgia's any different. We come up closer to 35,000 people. Maybe since this is a hearing, maybe before we get further, maybe there's a different role or a different group. I don't know if it would affect the fiscal note. If the numbers are
I
different,
wish I
they
had the
may have
fiscal note in front of
calculated
me.
it.
I
but-
actually might have it on me.
Mr. Chairman.
Yeah.
Oh, here we go. I have copies right here. I am stuck. There are a few copies there. Sorry about that. I forgot. My very efficient assistant had that fiscal note.
Okay, we can get that later. This is- Right now we do.
Oh, I see. I see. I see from your note that that's the number who are now paying more than 35. So many may not be paying 35 now. So these are just the ones that are using maybe a more expensive version or need a more expensive. Okay. Thank you. I understand.
And if I'm not mistaken, certain types of insulin work for differently for everyone. So some may need the more expensive, and some can work with the less expensive.
Just your presence here. Thank you.
All right.
And I think the analysis that, I'm sorry,
That's right.
Brandy Sullivan with the Department of Community Health. In the analysis that we provided when they made the fiscal note, we identified that about 78% of our members are already well below that $35 threshold. A lot of our members actually have a $0 cost share for their insulin. So the fiscal impact was not, significant, and that 2,400 is the population that we believe are currently paying more than $35. And our current covered lives is about 660, 665, somewhere in that range.
Even more.
Okay. Good information.
Very helpful, very helpful. That
Yeah.
was- we were trying to figure it. You get, so 78% of our folks are paying less than this already.
Correct.
Thank you. That's very helpful.
Happy to help.
Representative Kelly.
Thank you, Mr. Chairman. Senator, I guess maybe just a basic question. How do you decide $35?
It's just in line with some of the more popular caps that we have been seeing already. So that simply was it.
Okay. All right.
Yep. Representative Knight.
But I guess my question is getting back to cost. Do we know what the actual cost, not average wholesale retail price, you know, what is the true cost of these drugs? Have you looked at that from a point of view of maybe the retail, or I'll say that pharmacists, you know, are paying on average? Have you looked at what that is?
I guessed around, not guessed, but I've seen 175. I believe that is the cost of.
Okay, not to the patient, but to the retail. So if we went down the street to our local, I use independent pharmacists, but and see what their cost is as they are buying this, or is this only?
I would say under our state health benefit plans, what I did find it was $50.
That's what the cost.
The cost to our current it was $50.
Okay.
It was capped at 50. Yes.
But my question though is the cost of the actual product, not to the customer.
Yeah.
Or patient.
Yeah.
But to the pharmacy that is dispensing it.
Yeah. That number I would look at and get to you.
Okay. So we got some more to learn on this issue. Thank you very much. Good presentation.
Thank you.
All right.
Thank you, Mr. Chairman. Thank you, members.
You're welcome. Next up is Senator Watson with Senate Bill 223. I know that you have somewhere to be in about 15 minutes. So
I do. I appreciate your hearing me on this. I'll be brief. Senate Bill 223, LC 339402, helps Georgia Core, or the Cancer Coalition in the state of Georgia, get more cancer research done, basically. It allows or augments what is in law already relating to reimbursement of cancer trial participants, to reimburse them for their expenses, and that's what it does.
I think it's a very good bill. We've been through cancer in our family, and I can tell you it's a lot of cost along the way. It's not something you get one day and get better in 2 weeks. And there are families that really need this help. There's some families cannot afford the trips and the hotel rooms, and it's usually not just the patient, but it's the caretaker and the family. So I want to thank you for this bill. Thank you for all these families. Do we have any questions? All right, seeing none. Do I hear a second? Second. All those in favor say aye. Aye. All those opposed? Congratulations, you got your bill.
Thank you, Mr. Chairman, and I believe that you may have indulged me in carrying this.
That's right.
Thank you so much.
All right. Senator Huffstetler, I know he's on his way.
I'm right here.
Oh, okay. Sorry, I didn't see you come in. Great.
Got my bill out of the other house committee.
Yeah. Well, thank you.
Thank you.
All right, you've got two. You you have a preference?
I don't.
All right, let's do the first one, 164.
All right. This bill is actually a combination of two bills at the chairman's permission that took two bills with licensing that we did over there and combined them. One got out, the other one didn't make it out on crossover day. They both went through the GORC committee, the Occupational Review Committee over the off session, were approved unanimously. Both approved unanimously by the Health Committee. On the APRNs, what it simply does is says it doesn't change the scope of practice in either group, but on the APRN, they're still going by the RN license, and we've got multi-state compacts, we've got stuff going on, and we want them to have their own license, and this was at the request of the APRNs that they have their own license number, and this bill allows that. The second part of the bill for the AAs, the anesthesia assistants, not those in recovery, but anesthesia assistants that they're lumped together in the state and have been under the PAs, the physician assistants, and yet they're two completely different training programs and do two completely different things. I mean, I could argue that the AAs could do a PA job on the weekend, but they're not really qualified. And so they're trying to separate themselves out and have a separate category from the regular PAs. Because if you're a PA in orthopedics or OBGYN or general medicine or something like that, you went through the same program, maybe your training afterwards is different. But this is completely different training from the start. Basically a PA that would be similar to a CRNA. At our hospital, we've got about 13 AAs, I think 11 CRNAs that do the same job, get the same pay, all like that. And so this is just simply separating them out at their request from the regular PAs. And again, both these bills went through the committee and passed unanimously, both on the GORT committee over the off session and through the health committee and at the Senate side.
Okay, do I have any questions? Which, 9? Okay. Yeah. Go ahead, I'm sorry. Representative Jones.
Okay, thank you. I have a question about the page 8, line
And I probably
1.
need to get a copy of y'all's because for some reason when I came from another committee, I didn't bring it. So
Well,
here, I've got one. All right, I'm with you.
page 8, line 189.
Mm-hmm.
An anesthesiologist is a physician that completes a residency in anesthesiology. Do you know how long that residency is?
Generally, they're going to be about 4 years long. I think some of them maybe have been 3 years long, and then some of them go on and do things like a cardiothoracic fellowship. They get even more training after that, but it's as long or sometimes longer than medical school.
Okay, and then when I turn to page 10 on line 238, I see that the anesthesiologist assistant will graduate from an assistant program.
Mm-hmm.
So how long does that?
Well, first of all, you have to have basically a pre-med degree, and then the program itself is about 2.5 years long. So the way it works in Georgia, in many of the hospitals, some of the rules are just the CRNAs, but in Georgia, an anesthesiologist can supervise up to 4 rooms under the Georgia law, and either an anesthesia assistant or a CRNA would be in those 4 rooms, and then he's available to help out when needed. That's how Georgia does it, and it's a 4-to-1 ratio. It treats CRNAs and AAs exactly the same.
So they are in the 4 rooms, but the training doesn't last?
Not in rural Georgia, and there's some variations, but basically it's a 1-to-4 ratio for both of them, unless something unusual happens.
But they don't have as much training in being an anesthesiologist, only what they get from the graduate program?
They don't have near the training of an anesthesiologist, but this is current law. They're there right now. The CRNAs don't have as much training, but they're there right now in the current law, and that's why an anesthesiologist in many of the hospitals is there to assist in any of those 4 rooms if the need arises.
So was this taken from, this is my last question, was this taken from the bill that we voted down?
No, this has
before?
nothing to do with that bill. That bill dealt with CRNAs and did have some changes in it. This is existing law on both cases, on the advanced practice nurses and on the AAs. There's no new scope of practice. You could even argue less for the AAs because there's no need for a DEA license for a regular AA. It talks about getting a DEA license under the PA section. They're not just giving out drugs, prescriptions. They're only in the operating room. So they, under this new thing, they can't even get a DEA license. All this does is say we want to recognize that they are different than a regular PA and give them a section in the code that recognizes that. And we want to recognize that in the other section, the advanced practice nurse, should have her own license number as an advanced practice nurse, not just be using her RN license number, and that's what the nurses asked. But this has nothing to do with the bill that you had before at all.
Okay.
No scope of practice at all.
Thank you, Mr. Chairman.
Representative Mathiak.
I'm waving right now. Thank you.
Oh, you're waving? Okay. Representative Kelly.
Thank you, Mr. Chairman. Senator, I wanted to kind of get the lines 292 to 294 because I know we did have a pretty robust conversation in here last week about the role of the CRNA and how that played in with the anesthesiologist. Lines 292 through 294, where we're authorizing an anesthesiologist assistant to register with the DEA. What impact will that have on their ability to prescribe and handle certain prescriptions?
That would have to be given to them under board regulations, under protocol agreement. There's nothing there that that they need to prescribe outside the hospital. There's no one has ever in the anesthesia assistant program prescribes outside the hospital, only the drugs that they're giving there to the patient while they're doing it under the supervision of the anesthesiologist.
Are they currently authorized to register with the DEA?
They are currently authorized, correct.
Okay. All right. Thank you.
Representative Jones.
You answered it.
Yeah, okay. You like him
It's
back
still
on. Okay.
blank.
Okay. Any further questions? Okay, do I hear a motion?
Move to pass.
All those in favor say aye. All those against? Okay, one against. The bill passes. Yeah, who's carrying the bill for you?
Great. Let's see, I had Julianne McConnell, I know, had the person picked out for this. Now I'm drawing a blank because I was in another committee.
Did we have a sign-up list?
No, not to speak, just had a person picked out.
Yeah. I misunderstood.
I'll get with you after the meeting on that.
Yeah,
who
because
she's
we'll
got.
need that to go to the clerk's office. Okay.
Right.
All right, next up, Senate Bill 197.
All right, this bill is, it deals with, being transparent and this is the expert on this here, but it deals with being transparent. Again, if I, as an anesthesiologist assistant, I might get a PhD in that, but if I tell a patient I'm Dr. Huffstetler, I'm really not being genuine because I'm not a medical doctor in that role. And aside from that, there's specialties that may advertise things in public billboards or something that maybe aren't who they say they are. So this is just basically saying, let's recognize who we are and say who we are, and not confuse patients by saying, whether in a hospital setting or in advertisements to their home, saying that we're somebody that maybe we're not. There's the short answer to it.
Right. Well, it says all clinical settings, I believe, in there. So we're talking about clinics outside the hospital, right?
All clinical settings, anywhere
Right.
a patient is evaluated or treated.
Right. Okay. Representative, who we got first? Newton? Representative Newton.
Now, thank you for this. And you mentioned earlier as an anesthesiology assistant, and I've noticed one thing: a lot of our healthcare programs, the degree of illness required to take care of people in a hospital or something is increased. I know physical therapists, I believe, have a doctorate program now. Certainly, pharmacists like my wife, they're all doctors of pharmacy now. Is your goal? I know you call it the Consumer Information and Awareness Act, Senator Huffstetler. Is your goal to make sure that even though they have an advanced degree in a different field other than medicine, if it's in a healthcare, it is understood to be a healthcare setting, if they introduce themselves as a doctor, the patient will know that means they went, I think it says, went to medical school in residency and have a license as a osteopathic medicine doctor or a medical doctor, but they could still, as long as they specify that they're a doctor of physical therapy, they can still introduce themselves and call themselves a doctor, as long as at some point they've introduced themselves to say that's a doctor of physical therapy, not a orthopedic surgeon, for example, which might be confusing.
Point. I'm Dr. So-and-so, I'm a doctor of whatever, as long as you specify.
And for the rest of the time of that interaction, they can certainly, the staff can refer to him as a doctor, and that's not a problem, right?
It's all about lack of deception and clarity. So once it's made clear to the patient, then it's all good.
I've got a question for you then. What if it's a chiropractor in their own office? Would they still have to say, I'm Dr. So-and-so, I'm a chiropractor? I mean, patients would know that, right?
They would, assuming the signage is
Right.
is appropriately designated as Doctor of Chiropractic. or
But with this
Doctor of
legislation, will
whatever.
they still have to identify themselves as a chiropractor?
Technically, yes. But really, it's about the intent. If there's no intent
Right.
and their lab coat says Doctor of Chiropractic and the doorway says Doctor of Chiropractic,
Right.
then it's sort of
We're not
obvious.
going to be chasing those folks down, right?
No.
That's
Not
what I
at all.
thought. That's okay. Representative Kelly.
Thank you, Mr. Chairman. I certainly understand the need for this and want to know if there may be a way to expand on this. We're starting to see more and more people identify as doctors and all kinds of subject matters, and I think they mean for it to be taken in different ways, and especially I see it get thrown around a lot up here sometimes, and so I just want to know if we could expand this to cover all areas of our lives.
This is sort of a late date to make this a fat bill.
I could draw up a pretty quick amendment, Mr. Chairman.
I bet you could. Any more questions? All right. Do I hear a motion? Do I hear a second? All those in favor? All those against? Congratulations. You got both bills.
Thank you.
Who's carrying this one?
And Dr. Newton was going to
Okay.
carry this one.
Great. I want to say thank you to the committee today. Y'all did this in record time.
Thank you so much.
Thank you.
Very much appreciate you.
As of about 2 seconds ago.
Yeah.
Wow.
Is that mine?
Prepared, buddy. I'm taught twice and didn't have to give it either time.
I know.
The language had. I didn't know, but I didn't.
Sorry, I don't know.
If it's on my calendar, then yes.
Derek. I got Eric.
I just picked something off the table.
No raises.